Hello, everyone. So, you've all seen patients with high blood pressure, right? It's everywhere. But when you look at their prescriptions, the number of different pills can be, well, a bit overwhelming. Today, we're going to clear up all that confusion. We'll break down what these medicines do and, most importantly, how we, as doctors, choose the right one for the right patient. Let's get started.
And this is really the big question, isn't it? Why can't we just have one magic pill that works for everybody? Why this whole arsenal of medications? Well, I promise you, there's a very clear logic behind it all. And by the end of this session, you'll understand that logic perfectly. First, a quick recap. What exactly is hypertension? Now, we're not talking about a one-off high reading because you were late for class. No, we're talking about persistently high blood pressure. And the whole point of treating it is to prevent the serious long-term damage that it can cause if you just let it be.
And what is this damage? We call it target organ damage. You see, hypertension is famous as the silent killer because the patient often feels nothing. But silently, day by day, it's hammering away at the most critical parts of the body. It can cause a stroke in the brain, it can make the heart fail, it can destroy the kidneys, damage the eyes, it can even cause a catastrophic tear in the aorta. So you see, the stakes are very, very high. Okay, let's get into the drugs. Our first major class, and really the modern workhorses of treatment, are the RAS inhibitors. Now, these drugs target a key hormone system in our body called the renin-angiotensin-aldosterone system. Think of this system as the body's master controller for blood pressure. So within this class, we first have the ACE inhibitors. You'll know them by their names ending in pril. You know, like enalapril, lisinopril. These are fantastic drugs, especially for our younger patients, those under 55. And very importantly, they have a special protective effect on the kidneys, which makes them a first choice for patients who also have diabetes. Now, working on that same ROS pathway, we have the cousins of the ACE inhibitors, the angiotensin receptor blockers, or ARBs. You'll recognize these because their names end in sartan, losartan, telmisartan. They give you almost all the same benefits as ACE inhibitors, and actually, these days, they're used even more. So why is that? What's the difference between them? Well, the difference is all about how they work. On the left, you see the ACE inhibitors. They block the production of a very powerful hormone called angiotensin II. Now look at the right. The ARBs, they let the hormone be produced, but they block it from acting on its receptors. It seems like a small difference, no? But it has a huge clinical consequence, the cough. ACE inhibitors can cause this really annoying, persistent dry cough because they also affect other chemicals called kinins. ARBs don't mess with the kinin system, so no cough. And that's often the main reason we choose an ARB over an ACE inhibitor. All right, let's move on to our next big group of drugs. These are the calcium channel blockers, or CCBs. I like to think of them as the versatile relaxers, and you'll see why in a moment. Their main job is to directly relax the blood vessels. So how do they do this relaxing job? It's a pretty straightforward three-step process. First, they block calcium from getting into the muscle cells in the walls of our blood vessels. Now, you know that without calcium, muscles can't contract properly. So that leads to step 2. The muscle cells relax, and the blood vessel widens. And the result? Step 3. Lower resistance in the pipes, and the blood pressure comes down. It's quite elegant, really. And this is why we call them versatile. CCBs are especially good for patients over the age of 55 and for Black patients. But look at all the other advantages. They're safe in patients with asthma, they don't make people sleepy, and they won't mess with cholesterol levels. Plus, we have solid evidence that they are excellent at preventing strokes, a very useful class of drugs. Okay, now let's talk about a class of drugs that's been with us for a very long time, the beta blockers. You can think of them as the old guard. For decades, they were the absolute superstars for treating high BP. But now, well, their role has become much more specialized. And here is the most important update for you to remember. For treating just high blood pressure and nothing else, beta blockers are no longer a first-line choice. The big clinical trials have shown us that for preventing a first heart attack or stroke, other drugs like the ROS inhibitors and CCBs are simply better. But, and this is a very important but, this does not mean they are useless drugs. Far from it. For patients who have other specific heart problems, beta blockers are absolutely vital. We call these compelling indications. If your patient has had a heart attack or has stable heart failure, then a beta blocker isn't just an option, it's a mandatory life-saving medicine. So we have ROS inhibitors, we have calcium channel blockers, beta blockers. It can all seem a little confusing. Which brings us back to our main question. How on earth does a doctor actually decide which pill to give to which patient? Well, the answer is that we follow a very clear, evidence-based strategy. We don't just pick a drug out of a hat. We follow a logical, stepwise approach, just like the major international guidelines tell us to. It's a very systematic process.
Okay, so here is the battle plan. This is the entire modern strategy in one picture. It might look a bit complicated, but the starting point, step one right at the top, is based on two very simple things: the patient's age and their race. So for a patient under 55 who is not Black, we start with an ACE inhibitor or an ARB. But for a patient who is 55 or older, or a Black patient of any age, we start with a calcium channel blocker. See, that first big decision is actually quite simple. So let's just simplify that whole chart. Step one is picking our starting drug based on those factors. Now, if that one drug isn't enough to control the BP, we go to step two. We add a second drug from a different class, creating a two-pronged attack. Still not at our target? We move to step three and add a third drug, usually a diuretic. And for those very tough cases, what we call resistant hypertension, step four brings in a fourth specialist drug. It's a logical escalation, adding different mechanisms at each step.
And this really is the main take-home message. The reason we have so many different pills is so we can follow this personalized, stepwise approach. We don't just throw everything at the patient at once. We start simple, we choose based on the patient, and we add different drugs logically until we get the job done. This is what modern evidence-based medicine is all about. Now, one last very critical point. While this whole strategy is about combining drugs, there are a few combinations that are big no-nos. They're unsafe. First, you never ever combine an ACE inhibitor with an ARB. They do the same thing, and it just increases side effects. Also, we try to avoid a beta blocker plus a diuretic, as it can increase the risk of developing diabetes. And finally, combining certain CCBs with a beta blocker can dangerously slow down the heart. These are crucial safety rules you must remember.
So there you have it. Choosing a blood pressure medicine is not random at all. It's a sophisticated, personalized process. And this leads to a fascinating final thought for you. Today, we use age and race to guide our first choice. But what about tomorrow? In the future, will we be using a patient's own genetic code to pick the perfect drug from day one? That's the exciting future of personalized medicine. Thank you.
All right, everyone, welcome back. We are continuing with our chapter on antihypertensives, Chapter 41, Part 2. And today we are going to discuss something that is super, super high stakes. I mean, making the right call here under pressure is everything. This isn't just theory for your exams, okay? This is stuff you will use for your entire clinical career. So pay attention. Let's get right into it.
Okay, picture this. You're in your OPD, patient walks in. You put the cuff on and boom, this is what you see on the monitor. Systolic BP over 220. I mean, your own heart starts pounding a bit, right? So tell me, what is the very first thought that pops into your head?
And that thought leads to this, the single most important question you have to ask yourself. Because believe me, your entire management plan, it completely changes based on the answer. Is it a hypertensive emergency or is it a hypertensive urgency? Get this simple distinction wrong and, well, the consequences can be really, really serious.
So here's the thing, and this is the main takeaway. The BP reading, it can be exactly the same in both cases. The one thing, the only thing that separates them is this: active, ongoing target organ damage. We call it TOD. So what does that mean? Well, an emergency means something bad is happening right now. Damage to the brain, the heart, the kidneys, you name it. But an urgency, the pressure is dangerously high for sure, but the organs are, well, they're holding on for dear life. Everything we do next depends on knowing this difference.
Okay, so here's our plan for today. First, we'll nail down that key difference in a hypertensive crisis. Then, we'll dive deep into the kidney's master plan. You have to know the system to beat the system, right? We'll also touch upon a super important topic, antihypertensives in pregnancy. And finally, we'll get into the step-by-step management for both emergencies and urgencies. Cello, let's go.
Right. You know, to win any battle, you first have to understand the battlefield. And when we're talking about hypertension, the main battlefield is the kidney. More specifically, the nephron. If you can understand how this tiny little unit handles salt and water, I promise you, you'll understand how almost all of these drugs actually work.
So have a look at this. Here's the entire nephron, all laid out. The best way to think about it is like a super efficient processing plant. It has 4 main stations or sites, and it's so good at its job, it reabsorbs more than 99% of everything that gets filtered. So, what do our drugs do? Well, our drugs, especially the diuretics, are like smart little saboteurs designed to hit these specific sites and mess with that reabsorption.
All right, let's start with site I, the proximal tubule. This guy is the main workhorse of the whole operation. Just look at that number. A whopping 65 to 70% of all sodium gets pulled back into the body right here. It does most of the heavy lifting. But, and this is a big but, the rest of the nephron is so powerful, it has so much reserve capacity, that just blocking this one site usually isn't enough to make a big difference. Okay, now we get to the really clever part, the loop of Henle. What it does is brilliant. It actively pumps salt out, but it doesn't let water follow. So what happens? The urine inside gets more and more dilute, and the kidney tissue outside, the medulla, it becomes incredibly salty. This salty environment, this gradient, is the whole secret to how our body concentrates urine. And this, my friends, is exactly where our most powerful diuretics, the loop diuretics, like furosemide, do their work.
Now, if we zoom right into a single cell on that proximal tubule, we see this amazing little machine, the sodium-hydrogen antiporter. Simply put, it's a pump that does a swap. It kicks one hydrogen ion out and pulls one sodium ion in. This is a fundamental, absolutely key process for how the kidney manages the body's acid-base balance, because it's tied to reabsorbing bicarbonate. And because it's so important, it's also the target for a very specific class of drugs. You guessed it, the carbonic anhydrase inhibitors.
Okay, let's switch gears to a really important clinical scenario. A pregnant patient who has high blood pressure. I guarantee you will see this in your practice, and you absolutely 100% must know which drugs are safe and which ones are dangerous. Your choice here, it's not just about the mother, it affects 2 lives.
Okay, this slide, you need to memorize this. Just burn it into your brain. For safe drugs, Levotal is pretty much the first choice these days, the most widely used. Methyldopa is another great option. It has the longest safety record of all of them. Nifedipine and hydralazine are also on the safe list. But then look at the ones to be careful with. Propranolol has been linked with low birth weight. And sodium nitroprusside is a no-go and eclampsia. It is absolutely vital that you remember this.
Right, let's go back to that first patient. The one with a BP of 230 and, crucially, active target organ damage. This, my friends, is a code red. It's an emergency. Time is absolutely critical. We have to act fast, but we also have to act smart.
Now this is the golden rule. Please listen carefully. Your goal is not to bring the BP back to normal. Let me say that again. You do not want a normal blood pressure straight away. Why? Because the patient's body, their brain, their heart, they have adapted to that super high pressure to get blood flow. If you suddenly drop it too fast, you can cause a disaster. You could cause a stroke, a heart attack, ischemia. So what's the goal? A slow, controlled reduction. About 25% over the first 1 to 2 hours. Slow and steady wins the race here.
So, for a real emergency, we need to bring out the big guns. And that means IV drugs. All of these are given intravenously. Why? Because they work fast, we can adjust the dose minute by minute, that's what titratable means, and they wear off quickly. This gives us very tight control. You can see the whole list here. Nicardipine has become a really popular choice nowadays. And you see furosemide at the bottom? That's not a primary agent, it's an add-on, something we use if the patient is also fluid overloaded, like in pulmonary edema.
Okay, think of this table as your quick reference guide for the exams. It tells you which weapon to choose for which battle. So for most emergencies, and especially in stroke, nicardine is a fantastic choice. If you're dealing with a hyperadrenergic state, think pheochromocytoma or cocaine toxicity, labetalol is excellent because it blocks both alpha and beta receptors. For that classic dreaded case of an aortic dissection, sodium nitroprusside is the drug, but you must use it with a beta blocker. And finally, if your patient is in acute heart failure or having a heart attack, GTN is the way to go because it's mainly a vasodilator. Okay, let's completely switch gears now. Let's go back to that same patient with a BP of 230. But this time, there are no signs of any acute organ damage. This is what we call a hypertensive urgency. Now, I know the name has urgency in it, but ironically, our approach here is much calmer. We can actually afford to take our time. So the management here is actually very simple and much safer. Step 1, you double, triple check, make absolutely sure there is no target organ damage. Step 2, no need for IV lines, no need for the ICU. We're going to use simple oral medications. And step 3, the goal is a gentle, gradual reduction of blood pressure over the next 24 to 48 hours. See, no rush at all. It's a hurry up and wait kind of situation, and it's much safer for the patient. And here's our toolkit for an urgency, our oral drugs.
Levotalol and amlodipine are really our first-line choices. They work well, they're predictable. Now, you might see some older doctors still using captopril or clonidine, but honestly, we try to avoid them now. Captopril can have a very unpredictable response, and clonidine can cause sedation and nasty rebound hypertension. And please, everyone, look at the last point. The old practice of giving a patient an immediate-release nifedipine capsule to bite and swallow, that is dangerous, it's abandoned, it's unsafe. It can cause the BP to crash uncontrollably. Just don't ever do it.
So, we've come full circle, haven't we? Your next patient comes in. BP is 230/130. You see that number. It's staring you in the face. Before you even reach for a prescription pad, before you even think about a single drug, what is the very first, the most crucial question you must ask them? Think about it, because the answer to that one question, as we've learned today, changes absolutely everything.